everyone, welcome to Dr. Sam's anatomy classes. Here I'm going to solve this question paper of MBBS first year from RUHS, that is Rajasthan University of Health Sciences. This question paper is for students admitted in 2020. This is a main examination for those students, but this exam was conducted in January 2022. That's 11th of January 2022. Okay, so this is Human Anatomy Paper 1. It was having two sections. Section A, as usual, you know the pattern. There will be 6 fill in the blanks in section A, then 4 MCQs. Then there's a clinical question of around 15 marks, and then short notes of 5 marks, out of which you have to attempt any 5. 2 marks each, that makes 10 marks. And again there are short questions of which you have to explain only 3. These are 5 marks each, that makes 15 marks. Section B, this also is of 50 marks, and here you have short notes of 4 questions, so 5 each, that makes 20 marks. Then you have short notes, any 5 you have to attempt out of the 6, that will fetch you 2 marks each, that makes 10 marks. And explain briefly any 4 out of these headings, so that will make 5 marks each, that makes it 20 marks. So in short, you've seen this question paper. I'll be discussing all of these briefly, but my purpose is to explain you these MCQs, because these are scoring and you can score full marks in this. Okay, so let's begin with section A, fill in the blanks. The first question here is, cricoid cartilage in the neck lies at the level of dash vertebrae. So this question is about the vertebral level in the neck, and I hope you got this right. The answer here will be the 6th cervical vertebrae. Let's revise some important vertebral levels in the neck. Here you have is the thyroid cartilage. It's like this. Now this thyroid cartilage, when seen from front, it's like a half opened book seen from the posterior view, right? So this has this shape, and below to that is the cricoid cartilage. Both of them are unpaired cartilage, although posteriorly you have a projecting upwards cartilage from behind, that is epiglottis, which is an elastic cartilage. Let me tell you, there were 9 cartilages in this larynx. Out of these, 3 are unpaired: thyroid, cricoid and arytenoid. They are hyaline cartilages. But epiglottis, cuneiform, corniculates, including the apices of arytenoids, they are elastic cartilages. And now down below you find is this trachea, which commences from below to this cricoid and reaches down into the superior mediastinum. Above to this you have is this hyoid bone with this greater and lesser cornua like this. This is the hyoid bone. And here you find is this common carotid artery reaching up to this level. At this upper level, it has a dilatation which is called carotid sinus. From this carotid sinus, there's a bifurcation of this common carotid, which continues as internal carotid thereafter that. And here it gives its another branch, which is a minor branch, and that is called external carotid artery. So this dilatation at the upper limit of common carotid and at the base of this internal carotid, this is internal carotid artery, this is common carotid artery, and this one is external carotid artery. So this is called carotid sinus. Now behind this bifurcation, there is in the posterior surface of this bifurcation, there is this swelling, which is a mass of chemoreceptor cells, and that is called carotid body. So remember, B for body, B for baroreceptor, but it is not happening so. Got it now? Because there's normally confusion among students regarding which organ is a chemoreceptor and which one is a baroreceptor. Carotid body, B for body, but body is not a baroreceptor. Remember this way. Body is not a baroreceptor. It's a chemoreceptor. Carotid sinus is a baroreceptor. Carotid body is a chemoreceptor. Now, as we are learning here is the vertebral level of different structures which are important in your exam. So remember, from external carotid artery, the anterior branches given out here. One you can remember here is this artery is superior thyroidal artery. Now the superior thyroidal artery arises just below to the greater corner of the hyoid. Now at the level of the greater corner of the hyoid, there's this artery which is given out, and this is called lingual artery. There's an artery which is given out just above the greater corner of the hyoid, and this artery is called facial artery. You're learning the vertebral levels here. So behind this, all what you're seeing is the median structures. Like behind to this will be the cervical spine. So remember that this cricoid cartilage, this lies at the level of C6 vertebrae, and the upper border of the thyroid cartilage here, this lies at the level of fourth cervical vertebrae, while epiglottis reaches up to the level of third cervical vertebrae. And behind to this body, or you can say hyoid, hyoid actually is found between the upper part of the thyroid and between the chin. Actually it keeps moving while speaking and deglutition. So in a resting stage, the body of hyoid vertebrae lies opposite to the third cervical vertebrae. So in short, if it's asked like the level of larynx extends from C3 to C7 vertebrae. If it's asked like trachea, where does trachea commences from, or the upper limit of trachea, that of course you can write it as just below the sixth cervical vertebrae. Trachea begins just below to the C6, below to C6 cervical vertebrae. Of course, then trachea descends down into the superior mediastinum up till the fifth thoracic vertebrae, where it bifurcates opposite to the level of the sternal angle, that is between T4 and T5. So you find a carina there. So trachea bifurcates at the level of the sternal angle, that is lower border of T4 and upper border of T5. So what all are the structures that you'll find at the level of C4 vertebrae? One is the upper limit of thyroid cartilage. You will find carotid body, carotid sinus, bifurcation of common carotid artery. All this is happening at the C4 vertebrae. Now about C6, there are two important points to remember. One is the level of cricoid cartilage, and one more thing that you should know is that behind, I'm drawing it this way so you remember that this is the transverse process of the cervical vertebrae C6. So just in front of C6 there is a tubercle there. Anterior to the transverse process of the sixth cervical vertebrae, there is a tubercle, and this tubercle is called carotid tubercle of Chassignac. So this carotid tubercle of Chassignac has an importance that you can palpate for the pulsations of the common carotid artery opposite to this. It has a significance like in case of supraventricular tachycardia, giving a massage over this common carotid artery at this level of C6 vertebrae over to this carotid tubercle of Chassignac, it can help in relieving the symptoms of supraventricular tachycardia. Another thing is that this tubercle separates common carotid artery from the deeper lying vertebral artery. This vertebral artery is a branch from subclavian. It passes from cervical sixth vertebrae to the first cervical vertebrae, passing through the foramen transversarium. It does not passes to the foramen transversarium of the seventh cervical vertebrae. So at this level in the sixth cervical vertebrae, you will find that this Carotid tubercle of Chassignac separates the vertebral artery from the common carotid artery. So at 6 cervical vertebrae, you will also find is carotid tubercle of Chassignac. So these are the few important vertebral levels in the neck which are important for your exam purpose. The next question here is B. Dangerous layer of the scalp is. You can mention it as the fourth layer, or you can write it as loose areolar connective tissue layer. Now, to give you some idea about this scalp, the relevant questions regarding the scalp that usually come in exams. Now, what I have drawn, I hope you understood. This is the flat bone of the cranial vault, which is a diploid, means it has an outer table and an inner table, and in between is the marrow. And the flat bones, they are adjoined by this fibrous joint called a suture in between. The suture on outside is lined by this periosteum, and also from inside by periosteum. On the inside, it is supposed to be the outer layer of the dura mater, and that's why this is called endocranium. On outside, this is the periosteum lining the wall, and is called pericranium. But the important thing is that these two layers, they are connected with each other here at the suture, and this is called sutural ligament. Now inside, let me tell you, what you're seeing here, what I'm drawing here is the cerebrum. The cerebrum on outside has the cerebral cortex, and on inside is the white matter. So you're finding sulci and gari on the surface. Then let me cover the meninges first. Now the meninges, you know, here it is the inner layer of the dura mater, and that's called the meningeal layer of the dura mater. So you have two layers of dura mater. Outer layer of dura mater which adjoins the inner surface of the diploid, that's called endocranium, and inside you have another layer, and that's called the meningeal layer. So at around 4 such places you find in the cranial vault, in the cranium, that this dura folds on itself, the meningeal layer gets folded on itself to form spaces there, and these spaces, you can see, these are filled with the venous blood, and that's why these are called dural venous sinuses. If the suture, if you presume, like I've taken a coronal section, so the suture here, we presume it as the sagittal suture. This dural venous sinus will be called superior sagittal sinus. And on the lower free edge of this crescentric fold of dura mater called fox cerebri, there also you have a dural venous sinus, and that is called inferior sagittal sinus. Now below to this meningeal layer of the dura mater, you find is another layer of the meninge, which gives out these finger-like projections in the dural venous sinuses. These finger-like projections are called arachnoid villi, and it keeps lining the meningeal layer of dura mater from inside. And in older ages, these villous projections, they become pedunculated to be called as arachnoid granulations. These granulations, you can see, they press upon this inner layer of diploid, the cranial vault, that you will find sometimes in older age. The skull has depressions on either side of the sagittal suture. Those lacunar depressions are because of these arachnoid granulations. These are actually meant for the absorption of CSF and drainage of CSF back into the venous circulation. So this is arachnoid matter, and these are arachnoid villi in young age, then arachnoid granulations, which is pedunculated tuft-like thing on this villus projection, and those are you finding in older age. All these villi and granulations, the purpose is to drain the CSF into the dural venous sinuses. Now there is the third layer, the deepest layer of the meninge, which lines this cerebral cortex from the outside, and it's so closely applied to the cerebral cortex that it gets invaginated within the sulci. It dips into the sulci of the cerebral cortex also, like this. Now this is the thinnest layer of the meninge, and this red color one I have drawn is called pia mater. Although this pia also has two layers, one which is like closely applied to the cerebral cortex, that is called pia glia. The upper one, the upper layer, it is called epipia. Epipia actually helps to anchor those blood vessels which are running into the subarachnoid space. By the way, this space between the arachnoid matter and the pia mater, here you see, this space is filled with CSF, cerebrospinal fluid. And one of the contents, the important contents of CSF, the subarachnoid space, is that here you find is the cerebral blood vessels. These cerebral blood vessels give these cortical branches to the cerebral cortex, and few of these branches, they reach deep inside to the white matter, and those are called the central branches. Obviously, if they're going to dip deep inside to this white matter, they will be covering the sheet of pia mater along to their course. This pia mater invests or engloves these vessels like a sheath, and this sheath surrounding to the central vessels, the sheath of pia mater surrounding to the cerebral vessels, is called perivascular sheath of Virchow Robin's. You can call it as Virchow Robin's perivascular space. You can now presume it to be the cranial nerve. This cranial nerve arises from the surface of the brain, mainly from the brain stem. So obviously this, what I've drawn is cranial nerve. So this cranial nerve, obviously when it will emerge out, it will also be lined by these meninges. Not only the pia but arachnoid and dural sheath, dural coverings also. Now this is called epineural space. Now this space surrounding to a cranial nerve is called epineural space. Obviously when arachnoid matter will also surround to this nerve, then it will also have CSF. So the CSF in the epineural space communicates with the perineural lymphatics. That also is a one site for the drainage of the CSF, although that is a negligible amount. Now talking about the layers of the scalp, as we started with, above to the pericranium you find is a layer of loose areolar connective tissue on outside. Now this layer is the fourth layer of the scalp, and this has a loose areolar connective tissue. So this is the layer of loose areolar connective tissue. Then above to layer, this is the third layer. This third layer is a aponeurotic layer. This is aponeurotic layer, which bridges between the belly of two muscles. In the front, there is this muscle frontalis, and posteriorly in the occipital region, there is this muscle called occipitalis. And in between, this is called galea aponeurotica, which is a dense, thick, fibrous sheet made up of regular pattern of collagen fibers, antero-posteriorly running fibers. Then above to this you have is the subcutaneous layer. Now this subcutaneous layer is not very loose here. It is thick and because the scalp, the skin there is very hairy, and subcutaneous layer is having lots of subcutaneous vessels. It will be having subcutaneous vessels running, including, of course, the subcutaneous veins. And last of all, above most, you find is the layer called the skin. This skin, of course, it is made up of the stratified squamous keratinized epithelium. And this is a hairy skin. So it will have a lot of hair follicles. Remember how easily you can identify is because of those tufts and crests formed by this, dermo-epidermal junction. And of course, you will find is the hair follicles here, right? So this is a hairy skin. So this is the topmost layer of the scalp called the skin. This subcutaneous layer is also called connective tissue layer. It is actually subcutaneous, but for the convenience of learning the 5 layers, as you must have been told about the 5 layers means SCALP, right? So this becomes the first layer, means S for skin. The second layer is the subcutaneous layer, which you can call it with C for connective tissue, SCA. And then is the aponeurotic layer, that's the third layer, SCA. And then you have is L for loose areolar connective tissue, right? So loose areolar connective tissue is the fourth layer, and fifth layer is the pericranium, fifth one. So you got the formula of SCALP. Those are the layers of the scalp. And in your question, it was being asked about the dangerous layer of the scalp, and I told you that it is the fourth layer. The loose areolar connective tissue is the dangerous layer of the scalp. So this is the dangerous layer. Now, why it is dangerous? For that, you need to know about these emissary veins. You must have heard about that. These dural venous sinuses, they are communicating through these emissary veins, right? These are emissary veins or valveless veins which traverse both the table, like this is the outer table of the diploe, and this is the inner table of the diploe. So it traverses both the tables, the emissary veins, and communicates the dural venous sinuses out to the subcutaneous veins in the scalp. So the purpose is to maintain the intracranial pressure, to balance the pressure from inside to outside, and that's why these are valveless veins. There are other veins also. Let me complete it here also. There are some veins which pierce only the inner table, and occasionally these veins also drain to the outside, traversing the outer table only. So those veins which basically they mostly drain on the inside in the dural venous sinuses, and these are called the diploic veins. Mostly the diploic veins, they pierce the inner table and they drain into the dural venous sinuses, except in case if they ask, like sometimes, if it's asked like what diploic veins drain on outside into the scalp, then it's the frontal diploic veins, remember. So that question is important. Frontal diploic veins drain on outside into the veins of the scalp. Then rest of the diploic veins mostly drain on inside, and few in the occipital region also they drain into the subcutaneous region. Otherwise, most of the diploic veins they drain on inside into the dural venous sinuses. And these, as I told you, were emissary veins. So now think about this emissary veins. As I told you that the subcutaneous layer is a dense layer, right? Because it's a hairy skin. So the subcutaneous tissue is dense. So the veins do not rupture in the second layer. But remember, the emissary veins, actually it was asked it has already been asked in one of your exams earlier in some universities, that emissary veins drain into which layer of the scalp. So remember, emissary veins drain into the subcutaneous layer below the skin in the second layer of the scalp. But emissary veins are prone to rupture in the fourth layer. Why? Because the upper layers, SCA, skin subcutaneous layer, and the aponeurotic layer. These three layers are dense fibrous layer. And down below pericranium also is a dense fibrous layer. In between the loose layer is the fourth layer. So when you press upon the skin, you'll find that the skin slides over to this pericranium. The reason is there's a loose layer in between. So in cases of some laceration type of injury or some abrasions on the scalp, normally if there's a blunt trauma, even there is chances of rupture of emissary veins. So emissary veins easily rupture here in the fourth layer. So when these veins rupture, there is collection of blood here into the fourth layer. Chances of injury to the emissary veins in cases of delivery, like parturition at the time of difficult labor, sometimes we use the suction delivery. So when this, or some instruments like instrumental delivery, when you pull up the head of the baby, which is a mega baby, let's say. So when there is a suction applied to the vault of a fetus and to bring out the baby during the act of delivery, obviously after birth you find there is swelling on the scalp of the newborn, and that is because of collection of blood below to the skin, and that is called caput succedarum. One another such clinical condition is with the rupture of emissary veins below to the pericranium. So if there is rupture of these vessels below to the pericranium, what will happen? Of course, the blood will start accumulating here below to the pericranium. But the important thing is here, the blood collected here below to the pericranium will be localized to that particular bone. This blood will not spread over to the other bones because of this sutural ligament. The sutural ligament limits the spread of blood below to the pericranium, and this condition is called cephalhematoma. So this blood collected below to the pericranium will take the shape of the bone concerned. Like if it's like parietal bone, so that parietal bone is limited in with the coronal suture, it's limited from the frontal bone. It's with the sagittal suture, it's limited from the opposite parietal bone. With the occipital or lambdoid suture, it's limited from the occipital bone, and it also is limited from the temporal bone. So what happens if there is a leak of blood below to the pericranium? That blood will not spread to the rest of the bone, it will take the shape of the bone concerned, and that's called cephalhematoma. So I hope you've understood all the things which I have tried to explain it here, all the relevant important questions that can be asked in your exams. Remember, the dangerous layer of the scalp is the fourth layer, the layer of loose areolar connective tissue. Next question number 1C. Axillary nerve is the branch of dash cord. Answer will be posterior cord of brachial plexus. So the branches arising from the roots of brachial plexus. These roots are actually the anterior primary rami of the cervical nerves, including T1. Then there are trunks which are formed by the union of the roots, and then there are divisions. There are no branches arising from the divisions, and then there are cords of brachial plexus, and then there are branches arising from the cords of brachial plexus. So branches arising from the roots, one is phrenic nerve. Now this phrenic nerve has root numbers C3, C4 and C5. So it is a branch arising from both cervical and brachial plexus. Then there is dorsal scapular nerve. This has root number C5. Then there is long thoracic nerve of Bell, which supplies which muscle? Yes, serratus anterior. And the root number for this is C5, C6 and C7. Then we'll talk about the branches arising from the trunks. One is nerve 2 subclavius. But then this nerve has been seen sometimes to be arising from the roots as well. The root numbers for this nerve is C5, C6. So it arises from the upper trunk. But sometimes, as I told you, it might be seen to be arising from the roots of C5 and C6. So remember this point. Then there is this nerve called suprascapular nerve. Again, this has the same root number C5, C6. Then there are three cords, and these cords, they are in relation to the second part of axillary artery. This is axillary artery, second part. Lateral to this artery, this is called the lateral cord, running behind to this artery, and this is called the posterior cord. And there is a cord running medial to the second part of axillary artery, and that is called the medial cord. Now there are three branches arising from the lateral cord. There are 5 branches arising from the posterior cord, and there are 5 branches arising from the medial cord. So from the lateral cord, the branches will be lateral pectoral nerve, lateral root of median nerve, then musculocutaneous nerve. All of this has root numbers C5, 6 and 7. Same root numbers. Then the branches arising from the posterior cord are upper subscapular nerve, axillary nerve, lower subscapular nerve. Now these three nerves have this root number of C5, C6 only. Then there is thoracodorsal nerve, nerve 2 latissimus dorsi. Now this has root numbers C6, 7 and 8, the middle 3 segments of brachial plexus. Then there is radial nerve. For this there are root numbers, all of them 5, 6, 7, 8, T1. The branches arising from the medial cord are medial pectoral nerve, medial root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. All of this will be having root numbers C8, T1. Then finally, medial cord continues as ulnar nerve with root numbers C8, T1. But then ulnar nerve also receives a contribution from this nerve, lateral root of median nerve, also provides a communication to this, and then including this, then this ulnar nerve continues with the root number C7-8T1. Remember this, because medial cord of brachial plexus has the root number C8T1 only. But then during its course in the axilla, ulnar nerve receives a communicating branch from the lateral root of median nerve, mostly, but sometimes may receive a direct branch from the lateral cord, which gives its C7 component to ulnar nerve, and that makes it C7-8T1 the root numbers for ulnar nerve. And the diagram is still not complete because this lateral root of median nerve continues like this, while the medial root of median nerve joins this like this to form this nerve called median nerve. So in case if they ask the root numbers for median nerve, remember it is C5, C6, C7, C8 and T1, just like radial nerve. So median nerve supplies the muscles of the front of forearm through its lateral root, and median nerve supplies the 5 intrinsic muscles of the palm through its medial root. Right? Okay. By the way, the answer for your question is here, axillary nerve. You can see this was asked in your exam, and it is a branch from posterior cord of brachial plexus. Now the next question is 1D, spinal cord ends at which level? This is not a properly framed fill in the blank, because first of all they have not mentioned the age. If they are asking about the newborn or the infant or the adult, they haven't mentioned one thing. So we will automatically presume it to be that they are asking for adults. Then other thing is they have not mentioned about the level they are asking is in reference to which structure. They should have written it like which vertebral level. Then it would have been a completely formed statement. So it is not a very good fill in the blank. Anyways, so what I suppose you can write it here is spinal cord ends at L1, lower border. That is the first lumbar vertebra, the lower border. In adults, you could have extended your answer like this. And you can add up more, like in infants, including the newborns, that will end at L3 upper border, or L2 L3 junction also is correct. Next question here is 1E. Sub-occipital nerve is dash cervical nerve. So remember, first of all, even if you've written it as C1, then also your answer is correct. But to be more precise, you can write it as sub-occipital nerve is C1 posterior primary rami. It is the posterior primary rami of C1 cervical nerve. That's the first cervical nerve. Posterior primary ramus gives out this nerve called sub-occipital nerve. Important point about it is that it is a pure motor nerve. No cutaneous branch is given out from C1. So there is no dermatome. There is no C1 dermatome in human body. Very important point. Mind it. It might be asked in some other exam. Next question 1F. Embryologically, the parathyroid gland is derived from. You can write it here as endodermal pouches, but to be more precise, you can write it as superior parathyroid from fourth endodermal pouch, that is called the pharyngeal pouch. And inferior parathyroid is derived from the third endodermal pouch. It's called pharyngeal pouch. Okay, now let me cover up some important points regarding this pharyngeal pouches. So here we're talking about the structures derived from the endodermal pouches, which are actually also called pharyngeal pouches. Now this, what you're seeing is a coronal section of a fetal pharynx. Seen from the behind, in posterior view, means you're seeing is the endodermal surface of the pharyngeal apparatus. Now these surfaces which are invaginated inside on the endodermal side, these are called the endodermal pouches. From outside, These invaginations, when seen from outside, these are called endodermal clefts. And in between these two layers, this tissue here is the mesenchymal tissue, which is mesodermal, and this leads to development of lot many structures, including the muscles, the cartilages, skeletal muscles, and these are called the mesodermal arches. And these are numbered as 1, 2, 3, 4, and the sixth arch. So from the first endodermal pouch or the pharyngeal pouch, you know what develops is called tubotympanic recess. Now this develops into auditory tube, which also called as eustachian tube. The second endodermal pouch leads to the formation of palatine tonsil. And from the third endodermal pouch, it is the thymus that develops. It also gives origin to the inferior parathyroid, while the fourth endodermal pouch gives origin to superior parathyroid. Plus minus means it is suggested or it is hypothesized that there is lateral thyroid also being derived from this, and even they say that ultimobranchial cells, which leads to formation of those parafollicular C cells which secrete calcitonin, parafollicular C cells. Now this hypothesis is actually a hypothesis, or you can say that's a debatable point. Now the people have, the researchers have come upon to this finding that those C cells which secrete calcitonin, they're actually derived from the neural crest cells. In case if you get this question sometimes that parafollicular C cells are derived from, so better you mark that neural crest cells. I'm drawing it here. Let's presume it's out of this diagram. I think I should draw it here like this. This is supposedly the developing thyroid, right? So this is the thyroid being developed, and you know it develops from the thyroglossal duct, and some say that it also has contribution from the fourth endodermal pouch. As this third endodermal pouch, it descends like this. It carries those endodermal cells which are going to form the future parathyroid along with that. So these cells come to rest somewhere here, while those cells forming the superior parathyroid from the fourth endodermal pouch, they stay there in that position. What you get is collection of cells here and a collection of cells here. This is going to be formed as inferior parathyroid from the third pouch, and this is superior parathyroid being formed by the fourth pouch, right? So it is because of the descent of the thymus that the third endodermal pouch cells descend to form the inferior parathyroid, right? Okay. Now we're going to solve these MCQs. There are only 4 MCQs. The question number 1 here is safety muscle of the tongue is. By safety, it means which muscle actually prevents the falling back of the tongue so as not to block the gullet. So that muscle which actually protracts the tongue with its, and even in normal circumstances, because the tone of the muscle, the tongue stays in its position, it doesn't slips back, right? And so that muscle is, yes, it's genioglossus. Styloglossus retracts the tongue. Hyoglossus depresses the tongue. And there is one more extrinsic muscle, palatoglossus, which elevates the tongue. And there are 4 intrinsic muscles, as you know. Superior longitudinal rolls the tongue upwards, inferior longitudinal rolls the tongue downwards. The transverse muscles, they make the tongue cylindrical, thickened, rounded, while the vertical muscles flattens the tongue, spreads out the tongue. Got it? Okay, and that's why genioglossus is also called the life-saving muscle. Next question 2. Retraction of mandible is done by. Now there are 4 muscles of mastication. All of them are mentioned here. You should know the action of these muscles. In short, let me tell you that masseter, medial pterygoid, temporalis, all are actually elevating the mandible and helping in closing the mouth. It's the lateral pterygoid which depresses the mandible and helps in opening of the mouth. Apart from these, there are other actions as well. Lateral and medial pterygoid, they also help in grinding movements. At TMJ, they call these rotatory movements, causing the lower jaw to move left and right. While temporalis also helps to retract the mandible. Remember this. Temporalis over here is one muscle which is helping in retraction of the mandible. Then question number 3. The parental lobule is supplied by. This I think is a misprint. This should be paracentral lobule. Of course, they're talking about the brain. So the paracentral lobule of brain is supplied by middle cerebral artery, anterior cerebral artery, both anterior and middle cerebral artery, or Hubner's artery. So the answer to this is anterior cerebral artery. Anterior cerebral artery supplies most of the structures on the medial surface of the cerebral hemisphere, as well as it also supplies a strip 1 centimeter, 1 to 1.5 centimeter on the supralateral surface along the supromedial border. So here what you're seeing is the supralateral surface of cerebral hemisphere. So this is supralateral surface. And here you seeing is the corpus callosum, because this surface is what surface? This is the medial surface. So on the supralateral surface, you find this sulcus. The sulcus is a type of limiting sulcus, and it is also called Rolandic sulcus. It's a limiting sulcus, also called central sulcus. So it limits this, surface area, the gyri, anterior and posterior. So the anterior one will be the motor area, and posterior to that will be the sensory area. So this is the pre-central gyrus, and this is the post-central gyrus. This precentral gyrus is Brodmann's area number 4, and this postcentral gyrus is 3, 1 and 2. When you see it on the medial surface, here you find is the Sylvian sulcus. And you find that this central sulcus, it also reaches here on the medial side, including that post-central sulcus and precentral sulcus as well. Now this area, the precentral gyrus here and the post-central gyrus, the sensory cortex, primary sensory areas, also on the medial surface. Now together, this is called the paracentral lobule. This was asked in your exam. So let me tell you that this artery, anterior cerebral artery, which is a minor terminal branch of internal carotid artery. Because if it's asked internal carotid artery continues as, your answer should be middle cerebral artery. Then it gives its branches here like this, and these branches, remember, they reach and supply the supralateral surface of the cerebral cortex as well. This is anterior cerebral artery, a minor terminal branch of internal carotid. So on the supralateral surface, you will find these branches from the anterior cerebral artery coming and supplying this much area of the supralateral surface as well. This paracentral lobule, if they ask about the sensory motor homunculus, you must be knowing about that. Onto this surface, what is represented in sensory motor homunculus? Remember, in this motor homunculus, there will be representation of the leg, mostly the area of the leg below to the knee, that is represented here, including the bowel, means the rectum anal canal, and the bladder, the internal urethral sphincter and the anal sphincters. So obviously, if paracentral lobule is getting devoid, is getting going ischemia, so there will be motor and sensory loss in the region of the bowel and bladder, and down below to the in the lower portion of the lower limbs. So there will be paraplegia, there may be bowel bladder incontinence. In such condition, when there is loss of blood supply to the paracentral lobule, and this happens in cases of hemorrhage or infarct of the anterior cerebral artery. Remember this. Last question 2-4. Which of the following can extend, adduct and medially rotate the arm? Choices here are teres minor, subscapularis, latissimus dorsi and deltoid. Teres minor, what does it do? Teres minor, it actually helps to slightly help in lateral rotation of the arm. It is one of the muscles of the rotator cuff. Subscapularis is a strong medial rotator of the shoulder joint. Latissimus dorsi. Now, latissimus dorsi is arising from the lower back and reaching down and contributing to be the lowermost border of the posterior wall of the axilla and reaching and inserting into the middle impression on the intertubercular sulcus. So, latissimus dorsi, it actually, it's also called a rowing muscle, climbing muscle. So imagine of a rowing action when you're rowing a boat. So you are actually adducting and medially rotating your arms and then extending it behind. So that is the action of latissimus dorsi, rowing action. That is what they have asked in the question. Extend, adduct and medially rotate. Rowing action. Deltoid, remember, it can do all the actions possible at the shoulder joint. Flexion, extension, adduction, abduction, medial rotation, lateral rotation. And including these, it also can cause circumduction. Got it? Don't worry about the adduction thing about deltoid, because if anterior and posterior clavicular and fibers of deltoid and the fibers arising from the spine of deltoid, they act together, they will also help in adducting the arms. Right. Okay. Now let's read the other questions for those who are actually going to appear for the exams further. They might have some idea about the questions that have been asked. So this is a third one is a clinical question. A 10-year-old boy came to the hospital with a history of recurrent attacks of sore throat. On inspection of the oropharynx, the palatine tonsils almost touch each other in the midline. So it is a case of oral infection which might have led to irritation of the tonsils and leading to tonsillitis, a severe tonsillitis. Name the structures is forming the tonsillar bed. This is the gross anatomy question. Describe the arterial supply of the tonsil. Very important. Microanatomy of tonsil. Very important. I have been telling you it is a partially encapsulated lymphoid organ, lining epithelium, stratified, squamous, non-keratinized epithelium. And one important word about this tonsil is that it does not have any afferent lymphatics. Instead, it has tonsillar crypts. Development of tonsil, I just told you in the above question, it's from the second endodermal pouch. Then peritonsillar space and its significance. Of course, it becomes common site for infection. Question number 4. Write short notes any 5 herbs point important and nerve supply of tongue super important, both general sensory, special sensory, motor. Nerve supply to write. Then biceps brachii muscle and arteries. We do not have a collateral branches. Very important because if it undergoes infarction, it might lead to permanent damage to the structure supplying. Example, you can write it as the central artery of retina. Very important artery. The central arteries, central branches of the cerebral arteries. They are also end arteries. Transitional epithelium, also called urothelium, fertilization and the stages of fertilization. These are very important questions. Next is explain briefly any 3. Mid-palmar space is the medial 2/3 space because the lateral 1/3 is the thenar space, right? And remember that mid-palmar space does not contains the tendons for the index finger. The tendon of flexor digitum superficialis, flexor digitum profundus for the index finger, including flexor pollicis longus. These 3 tendons are a content of thenar space. So you have the long tendons for the medial 3 digits. That makes 6 tendons, along with the second, third, and fourth lumbrical. Remember, that's why the second lumbrical is unipinnate, because there's a vertical septa which passes down between the tendon for index and middle finger. So that's why the second lumbrical is unipinnate in humans, unlike the second lumbrical in the foot is bipinnate. Relations of the cavernous sinus, of course there are nerves running in the medial wall in relation to this internal carotid, this abducent nerve. Then in lateral relations, it is this oculomotor nerve which actually divides into upper and lower division of oculomotor nerve. Then you have the fourth trochlear nerve, then V1 that ophthalmic nerve, and V2 is the maxillary nerve. All these nerves you find in lateral relation to the cavernous sinus, but remember V3 is not in lateral relation. V3 is mandibular nerve. It soon descends down in the middle cranial fossa, comes out of the foramen ovale. Lymphatic drainage of the breast, super important. Classification of synovial joints. Remember there are 7 sub varieties of synovial joint. One is the plain synovial, then you have is the hinge joint, then you have a pivotal joint, condylar joint, then saddle joint, then ellipsoid joint, then ball and socket variety. Section B, here you have described the thyroid gland under the following headings. It was a big question. That's why I keep repeating. Remember, you should follow the previous questions papers. There's few questions which generally come in long questions. So it's a 20-mark question. You have to write the gross anatomy of thyroid, relations, blood supply, and the clinical anatomy. Remember, thyroidectomy is important. The thyroid is storm thing, the true and false capsule thing, then superior and inferior thyroidal arteries and the relations with the external laryngeal nerve and the recurrent laryngeal nerve. All what is important in relation to thyroidectomy is important. And don't forget to mention about this blood supply, the thyroid imma artery and the vein of Kocher. All this is very important because the teachers, the examiners generally, search these little things in your answers. Write short notes on any 5 branches of external carotid artery. Super important hai bhaiya. Anterior branches, medial branches, posterior branches. That is how how you're going to write it. So the branches arising anteriorly from this external carotid will be superior thyroidal artery, lingual artery, facial artery, and I already told you in some of those MCQs or somewhere that the 3 arteries lie in relation to the hyoid. Superior thyroid artery arises just below to the level of the greater cone of the hyoid. Lingual artery arises at the level of the greater cone of the hyoid. Facial artery arises just above to the greater cone of the hyoid. These are the anterior branches. What is the medial branch? Of course, the ascending pharyngeal artery is the medial branch. Then there are 2 posterior branches. Those are the occipital artery and the posterior auricular artery, right? So occipital artery, remember, very important point, occipital artery arises at the same level as facial artery. And these branches, occipital artery, posterior auricular artery, they're rising and running above and below to the posterior belly of the digastric muscle. But important point is that occipital artery arises at the same level where you find is the facial artery. This has been an MCQ. Then, of course, the artery passes through the parotid gland, and there it gives out its terminal branches, just maxillary artery, and then finally superficial temporal artery, which runs anterior to the tragus of the pinna. Upward movement of the eyeball, very important. Upward movement will you can include is superior rectus, inferior oblique. This is in case of right eye. Left eye, it will be superior rectus, inferior oblique. This will be left eye. Internal oblique not only elevates the eyes, it also causes intorsion, as well as it also helps in lateral deviation. And superior rectus helps in extorsion as well as in adduction. But the question here is about upwards movement of the eye, so the answer will be inferior oblique and superior rectus. Because they have not mentioned eye, so you just have to simply write inferior oblique and superior rectus. Parotid fascia, very important. Remember that Petty's fasciovenous plane, that also is important in case of parotid gland, because that's important for the resection of the parotid gland. And there you have to be very conscious while you're doing parodontictomy. So knowledge about parotid fascia is important for doing parotidectomy operations, because you have to be cautious about those branches of the facial nerve, external carotid artery, and the retromandibular vein. All these structures are there. Then placental barrier, for this you need to remember the primary, secondary, tertiary villi, especially the tertiary villi. So structure has to be known about that. Wrist drop, of course, when you talk about wrist drop, it is the injury to radial nerve above to the elbow. Substantia nigra, of course, this is very important. The coloring pigmentation found in the midbrain crus cerebri of the midbrain. This area, if it gets degenerated, may be responsible for this disease called Parkinsonism. Explain briefly any 4 spinothalamic tract. It has anterior and lateral divisions. The lateral spinothalamic tract generally conveys the pain and temperature sensations. Auditory tube, eustachian tube, very important. Medial cord I described with the fill in the blanks above. Transverse section at level of pyramidal decussation. So transverse section, the level of pyramidal decussation. Here you need to draw the transverse section of the medulla oblongata at its lower level. Then development of tongue is super important. You need to know this development of tongue. I think this is done. Okay.